Good evening, everybody. We've got plenty of you joining us already, so welcome. We'll get underway for the evening. Welcome to the latest joint event between BASRAT and Steriplast for the Injury Rehab Network Northwest. My name's Ollie Coburn. I'm from BASRAT and I'm hosting alongside Andrew Watson from Steriplast this evening. As we get going and as we're doing introductions, please do feel free to introduce yourself in the chat box. It's always nice to know who we've got with us and where you're from and what you do for work, so do let us know. A few housekeeping bits. We will send certificates of attendance to you all joining us live this evening. You'll get those tomorrow by email, so just be patient with us. Tonight's presentation will be around 30 to 40 minutes and we'll follow that up with a Q&A at the end. If you can see the slides at the moment, if you just take a look at the Q&A button, if you click that, the questions will pop up and you'll be able to see what's already been posted. If there's a question there you like the look of, or somebody's already asked what you were thinking of, please just upvote it and it'll bump it to the top of the list, because we do like to take the most popular questions at the end of the presentation. We are recording. We'll make tonight's recording available for a limited period of time after the event, so that if you do miss parts of it, there's bits you want to catch up on, you can do that. Very quick bit about BASRAT. We're the professional association and regulator for sport rehabilitators. We run these events regularly, both in combination with Steriplast. We've got a full calendar for the year, and we run some independently as well. If you want to support our work, you can do so by becoming an associate member, and you get access to all of those benefits that you can see there. If you are interested, just pop us an email. That's enough from me. Andrew, I'll hand it to you to do a very quick introduction to Steriplast and lead into our guest speaker this evening.
Thanks, Ollie. Hi, everyone. Thank you very much for joining. Great to see so many people. And I've no doubt that's because Diane is a fantastic speaker. And I'm sure everyone's going to find Diane's presentation really interesting this evening. So thank you, Diane. We'll let you introduce yourself shortly. But just quickly, just to introduce myself, I lead on our work in sport, Steriplast Healthcare. As a business, we've been going over 25 years, working in the healthcare, sport, and across 7 different sectors. It's really first aid and medical products for sports injuries, and we work in partnership with sports teams, national governing bodies, sports rehabilitators, and we're really pleased to work together with BASRAT to add some value and to support the good work that BASRAT are doing in sports rehabilitation. So with the Injury Rehab Network, the group started in 2019 really as a local network for professionals involved in sports injury in the northwest of England, and the format was usually an expert guest speaker as part of a face-to-face event, and then some networking and collaboration, and that group grew during the course of that year. But due to COVID, we had to have a rethink, and actually it's been a fantastic thing for the group, because in partnership with BASRAT we've been able to widen the audience, and we've had some fantastic speakers this year. As you can see, there's a great plan following on from Diane's talk for events this year, so please do keep an eye on BASRAT and our website for the events that we've got coming up. The next one with Professor Bill Ribbons in May will be focusing on his work as a surgeon and in on ankle injuries. But yeah, that's us. And thanks again to Diane for talking tonight. Really appreciate your time. Thanks, Ollie, for hosting as always. And thank you everyone for joining. So as I said, I think it's best for people to introduce themselves. So I'll hand over to Diane and let you do that. But thanks very much, Diane.
Thanks, Andrew and Ollie, for inviting me to speak this evening. Just share my slides and hopefully be underway. So, so my role at Manchester United is Head Foundation and Youth Development Physiotherapist. And that means I look after the academy players and the physiotherapy team for the under-9s to under-16s players. And tonight I'm going to talk about both the common paediatric injuries presentations that we get and also the ones that we really don't want to miss when we're working with peds. So And we have the Ollie, it's crashed.
Oh no. Do you want to if you stop your screen share and then reshare it and see if we can do the whole off and on again?
Let's start from the beginning. Start from this one. See if this one works. Okay. There we go. All right. So,
we can't see that at our end.
Yeah,
Give me a second.
Let's try again. Okay. Get that now?
Yeah, if you're going to presenter mode, we're with you. Got you.
Yeah.
Yeah, we're there. I assume you're on the academy slide, yeah?
I am, yeah.
Magic.
Right,
we're good.
Try again. All right. So basically many people start off their sporting careers when working in an academy or a youth team setup. From my experience, not many people come into this role with lots of experience working within paediatrics. So for many people, it's walking into a world of completely different terminology. So apophysitis, osgood-Schlatters, I'm just going to move everything because I can't see it. Severs, etc., Sinlin-Larsen, epiphyseal plates, Salter-Harris fractures, etc. So, and the reason that all these terminologies come in and that they change is because of growth. So we need to first of all talk about growth. So you can see here that the skeletal systems of adults and children are very different. So, and it's mainly relating to this epiphyseal growth plate. So you can see here it's open on the child's x-ray and it's closed on the adults. And a key point is that tonight when we're going to be talking through epiphysis contributes to a joint, and anything with apophysis or apophysitis, it relates to a teno-osseous attachment. So what is the age of the player that you're rehabilitating? Well, age can be numerous things in relating to the developing player. We have the chronological age, which is the age in relation to the date of birth. Then we have the biological or skeletal age, which relates to maturation and can be calculated by methods such as the Camison-Roach procedure. And you can see that chronological and skeletal age don't always match. So two boys here, very similar chronologically, but very different in relation to the state of maturation. The other thing that we need to consider is the psychological age, and this refers to the emotional, cognitive and psychological development of the player. So a player may reach the adult height in the mid-teenage years, but it doesn't mean that they're necessarily processing like an adult. So what's the maturation status of the player that you're working with? Are they early, are they on time, or are they late? So let's take a player whose chronological age is 14. Biologically, if their age is within 1 year either side of that 14, then they're within normal maturation parameters. Anything beyond this, either ahead or behind, they become an early or a late maturer respectively. So for example, chronological age 14, someone within that age group could have a biological age of 16 or a biological age of 12. So within one age group, you could have 4 years difference in biological, although chronologically there's only 1 year difference. And that's important just to be aware that throughout the talk, I'm going to talk about what kind of ages do these conditions present at, and just be aware that this is a little bit flexible because of maturation. We know that within our own academy, a study in 2009 by Mandy Johnson found that a third of players were shown to be outside of the normal maturation category, with different maturity rates in different ethnic backgrounds and earlier osseous maturity in female adolescents. And it's this earlier osseous maturity that does change the ages that conditions occur in both males and females. So we'll look at the child-centered assessment. Young children may not offer information as freely as adults. So quite often with adults, we use a lot of open questions and they'll tell you all about the condition. But in children, sometimes you have to pin them down a little bit more in relation to the closed questions that you're asking. And I find that creating a verbal timeline can be really helpful for the child. And remember that if they say something started ages ago, this could mean 10 days ago. Beware of the child who seems a little bit, maybe a bit sheepish, maybe a bit fearful of getting into trouble. You know, is there something else going on as well? Is there anything else contributing factors? So I'll give you some examples of ones that we've had at the club. Most recently, we've had a boy with back pain because he was sat on a chemistry stool all day because of COVID. They moved classrooms. So he had some back pain. We have children who were doing multiple sports. Obviously, the boys at our academy are sporty kids, so they'll often be involved in school football teams. They might be involved in cricket in summer and academy football. So just being aware of what they're doing around the academy as well is really important. We've had back pains that have presented following children getting new video games and spending the weekend kind of lied awkwardly on the couch. And we've had even kind of more stranger ones, like a child came in with coccyx pain and we couldn't work out what was going on with this child. And then it turns out that although there's no snow in Manchester, this child's been in Wales for the weekend and sledging the whole time. So really you need to pin down what they're doing other than just the football. From a parent's perspective, are the parents present at the assessment? Well, this can be a bit challenging when at the times of COVID and we're trying to limit numbers on site, but it's really important, especially with the younger children, that they are, if they can be. Head injuries, really, we need parents with them for any head injury review. You can't relate to just what the child's telling you. So at the absolute minimum, they need to be contacted on the phone, but ideally you do want them with you. Using the IDT to get subjective history. So has anyone's been an eyewitness, a coach or a sports scientist? Is the video analysis available that you can go back and look at? Was there any other preceding factors to the injury being reported? Were they struggling? Were they having a bit of a bad game? And that Osgood that they have just started flaring up? And have they had lots of previous or repeated visits to the academy medical room? So a common subjective assessment tool that we use is the numeric pain rating scale. So if nothing's no pain and 10's the worst pain you can ever imagine, and we said to the kids, think of a shark biting your arm off, loads of sharks in Manchester. But, how much is your heel pain? So for 7's, and sometimes they'll have got through a full game and they're not even limping at this point, and they might be thinking, and you'll see them ticking over and they'll go 7. Okay, and I think they probably think, well, it is really hurting, so it's not kind of like 2 or 3, but maybe it's not a 10, and it's really tickles me that quite often we get the number 7, and I think it's probably because as well that their experience of pain is limited, especially in the younger players. So the next question that I ask myself is, are pain scales valid for the use in academy players? And the answer is yes. So numerical pain rating scale is reliable in children over 8. Wong and Baker face pain rating scale and face pain rated scale revised are recommended for use with 5 to 12 and 13 to 18-year-olds respectively. And the VAS scale is recommended for children over 8. So yes, we can use these as part of our subjective assessment. Throughout the subjective assessment, we need to consider the communication that we're using. So we're trying to make sure it's age appropriate. We're going to use lots of visual aids or models in communication, and we're going to try and confirm their understanding. So ways that we do this is, can you explain your injury to me? Can you tell me what you think is going on? Or it might be things like, where do you think you are in relation to return to play? What do you have to do to get back to return to play? What we also sometimes say to them is, generally as physios, we want to know, has someone got some questions? But if you take anything away from this talk, think about this. If you ask any questions, the response that you get is no. And it's very quick because it's very close, really, not really inviting any questions. But if you change your language and you change it to what questions do you have, you get a very different response. Just try it with your next patient. You really see them starting to think, well, what can I ask? I think at the times that we're in, it means communication is just even more of a challenge. Obviously, at times we're doing rehab virtually when people are isolating, or just even having to wear a mask, I think can be really challenging. I think we use a lot of facial expressions, especially with children, for them to know what we're thinking, or smiling. And I think we need to be very clear sometimes to the kids, saying, can you tell, I'm happy, or just explaining a little bit more your emotional state, because it's really difficult with masks. I think it's difficult as adults, but it's even more difficult as children. So just to give you a little task for just 30 seconds or so, here's some paediatric x-rays before we go into the objective side of the presentation. And just if you can have a little go at guessing what the x-rays are. So I've put arrows on just to make it a little bit quicker, just because obviously we're a bit time limited. So I'll just give you a few seconds of that.
Let's see some answers in the chat, guys. Come on, who's brave enough?
Mm-hmm.
Don't forget the questions into the Q&A box as well, please. Post them as we go through, if you like, and then everyone can check in on them.
I can't see what's coming through all of this, so you just have to shout out.
No one's been brave enough yet.
No one's there. All right, we'll move on then.
We've got, Colin Kohler's, but he's not said which one. C, Taylor Dome.
Yeah. Yeah. Very good.
B, Freiberg's.
Yeah.
What else we got? Some people not putting the...
It's all right. It's a buccal fracture. So yeah, well done. So we've got a buccal fracture here, Freiberg and Kohler's. Brilliant. So being aware of paediatric pathology is obviously the main part of this talk tonight. And I'm going to split it into osteochondroses, fractures, and then serious or sinister pathologies. Now, there is loads of these, so I can't really quite cover everything. I'm going to pick some from this list to talk about tonight. So we're going to start with our kind of bread and butter ones, which are the non-articular osteochondroses. So Osgood's and Larsen's, Severs and Iceland's. So Osgood-Schlatter's, it's a traction apophysitis of the tibial tubercle caused by repetitive strain on quadriceps tendon. In boys, its onset is around about 12-15 years, and in girls around about 8 to 12 years. Signs and symptoms, pain and tenderness of the tib tubercle. So if you say to them, where is your pain? One finger, they'll generally put it straight onto the tib tubercle. They generally report that pain's worse either during or after sport, and they might, when you assess them, have some tightness in the quads or the lower limb muscles due to a recent growth spurt. So what happens is the bones grow, and then the muscles take time to adapt around, which can mean that they can be tight. And they may present with or have a permanent painless bony prominence over tib tubercle. We always check the biomechanics because they may have something like an overpronation or rear foot varus that we might get the podiatrist to look at. This is a clinical diagnosis and can be seen on ultrasound, MRI or X-ray, but generally we just use it as clinical diagnosis. In your older athletes and your adults, this will probably be more likely a tendinopathy if you had pain in this area. Syndrome Larsen-Johansson syndrome. This is a form of apophysitis which affects the proximal patellar tendon at its insertion and the inferior pole of the patella. Again, one finger, the children can generally point exactly to where the pain is. Age range is 10 to 14 years, a little bit younger, and signs and symptoms, pain, tenderness, kind of point tenderness to the pole of patella, can be unilateral or bilateral. Again, worse during or after sporting activity. Things like squatting would aggravate in the treatment room. And again, they may present with tightness in the quads because of that recent growth spurt. So how do we manage these two conditions? Well, it starts with education. You know, this will improve as you grow, as everything kind of readdresses itself. Physio will do a lower limb strengthening program, so quads, glutes, etc., and we'll address any muscle tightness that's occurring. We'll look at any neuromuscular control issues or any proprioception deficit, and we'll refer to podiatry if needed. If the player is of low irritability, then we'll just reassure them they can continue to train with self-management. So they might be like, come and get a bag of ice at the end of training and just do your home exercises as well to manage. If it's moderate irritability, then we will do activity modification within the painful phases. So it may be that they'll just do the technical aspects of training, for example, and we're going to consider the intensity, duration and frequency of training. So basically, these are going to kind of remain within the training phase, and I'm going to return to training competition, hopefully, relatively quickly. If someone is of high irritability, then we might need to give them a period of relative rest, but we'll use this time to work on their individual plan. So it might be that they'll spend time with analysis or with nutrition, psychology as well. So using the MDT. So we're really just using that time as a value-added time that they're injured, as well as trying to rehabilitate them as well. We're going to strengthen and continue within pain limits too. So Severs disease is one with the youngest age groups that we get. Commonly, we find it in the foundation phase, but can go up to 15 years. And this is heel pain relating to the calcaneal apophyseal growth plate. And quite often, in adults, this would be more like a tendon, tenomuscular, tenoosseous junction issue. In children, Sever's disease, they get like pain and tenderness, but it's not just at the insertion of the TA into the calcaneum. It can be around both sides of the calcaneus, and it can actually be underneath as well. It can be bilateral or unilateral, and they'll get pain when you just get them in the treatment room to do heel raises repeated or hopping. These again will come in generally report after the session saying that the heel pains have started to get worse. We'll assess them and look for any TA or soleus tightness, and we'll review for any biomechanical abnormalities. So things like rear foot valgus position may impact the windlass mechanism, and it might change the force at the TA. We're going to get them to walk up and down. I'm going to observe any early heel raise, because this might increase the load on the TA and therefore increase the pain in their heel. We also observe if there's a leg length discrepancy, because if there's a leg length discrepancy, it may be putting, again, increased load on the TA of the opposite leg. So what about treatment? Well, literature study by James showed little methodological rigorous evidence to support treatment options for calcaneal apophysitis. So it's generally this suggested advice, education, stretches and strengthening. But what about heel raises? Okay, so let's look at the literature for whether heel raises are appropriate for Severs. So this study in 2016 compared the use of heel raises to eccentric exercises and then to a wait and see approach, and reviewed the children at 6 weeks and 3 months. And each resulted in a clinically relevant and statistically significant reduction of heel pain. From a child-reported perspective, at 6 week stage, the heel raise group had improved more than the wait and see group. From a parental perspective, eccentric exercises improved more than the wait and see group. So in conclusion, patients and parents should be consulted about their preferred treatment option. Another study by James in 2016 determined an advantage in the use of heel raises over prefabricated orthoses at 1 and 2 months. And at the 6 and 12 month stage, there was no relative advantage of either of the treatment approaches, which is good because if you don't have access to a podiatrist, you could use just heel raises. So heel raises at the initial stages may aid children with Severs to remain physically active. So yes, do we use them at United? Yes, we do. Other advice that we would give children is things like avoid kind of really flat shoes like Converse. If they're in a flare-up, we'll get them to wear trainers even in the house, which has got the cushioned insole and maybe kind of more of a little heel like a running trainer, and that kind of tends to offload them as well. So next on to Iceland's disease, which is traction apophysitis of the 5th metatarsal base. And you can see that there's lots of differential diagnoses around this area. So from stress fractures, Jones fractures, avulsion fractures, ospicalianum, perineal tendinopathy. But we're just thrown in the mix because of the age now. We could have a traction apophysitis as well. So this apophysis appears on radiography approximately 8 to 11 years in boys and 11 to 14 years in girls, and it fuses by around 17 to 18 years. But they think that because of repetitive trauma due to the peroneus brevis tendon, this is what starts the issue. It's a clinical diagnosis, but X-ray may be required to rule out a fracture or an ospicalianum. Treatment and management plan. It's basically very, very similar to, we talked about the apophysis treatment and management principles for Osgood and Sinlin, but they might need a period of immobilisation in, say, an Urcas boot, or occasionally they can go to surgical excision. So now looking at more the articular osteochondroses. So starting with colours, so this is a sclerosis and flattening of the navicular bone, and it can just be an incidental radiographic finding. Age range is approximately 5 to 6, but cases can occur in 2 to 11-year-olds with a male to female bias. So these patients will get pain with weight bearing, midfoot and medial border pain and swelling. And the literature says it's self-limiting in nature and it can be just managed symptomatically. Freiberg's is an articular osteochondrosis of the metatarsal head, and it's commonly the second metatarsal head. So that's about 68%, but can occur in other metatarsals as well. Again, female to male bias with mean age around about 18.3. So these are your older academy players. So symptoms, these players will present with pain, swelling, and a small effusion or callus potentially under the affected metatarsal head. And these are going to be managed with immobilisation in something like an Urcast boot. They're likely to have orthotics and maybe some padding just to kind of offload pressure from that metatarsal head. Osteochondritis dissecans. This is a really important one that we're aware of because it's an idiopathic alteration of subchondral bone, and there's a risk of instability and disruption of the adjacent articular cartilage that may result in premature osteoarthritis, but also osteochondral defects as well. So the age range is around about 12 to 19 years old, with the mean age being 10 to 13 years, with male to female bias. Now, the key is that these may be vague. It may be just that activity exacerbates the pain. It may be poorly localized, so it's not the point one finger at your pain and they can point to tib tubercle on Osgood. This is a vague, poorly localized pain. If they have a mechanical symptoms, you might be thinking about a loose body. And the key, these ones may come in with a joint effusion. So they may have then limited range of movement. They could have point tenderness over the affected femoral condyle, and quite often it's the medial one. And quadriceps atrophy would be a late finding, so hopefully we wouldn't find that in sport at that point. But the key point here is that osteochondritis dissecans do not discount near fusion as growing pains. Intra-articular near fusion is not a growing pain. You don't get that with Osgood or Sinlin-Larsen. And don't just discount these vague, poorly localized pains as anterior knee pains as well. If we're in doubt, we're going to send them off for an MRI, and management then, if the MRI shows that it is osteochondritis dissecans, it can be a surgical or a conservative approach, and that depends on the fascial status, so the size and the depth of stability of the lesion. So on to fractures now. So first of all, again, when we're thinking about applying things that we do with adults to children, the Ottawa foot and ankle rules, we use these a lot with adults, but what I wanted to know was, can we use these effectively with children? And the answer is yes. These are a reliable tool to exclude fractures in children when presented with ankle and midfoot injuries. Sensitivity is around about 98.5%, meaning that only about 1.5% of fractures may be missed using these rules. Same with the Ottawa knee rules. These are validated for children over 5 years old, but just be cautious really, because intra-articular fractures may not be seen on plain radiographs of skeletally immature athletes. We have had players gone to A&E with a suspected fracture. We've been told that there isn't a fracture. They've come back. We've not been quite happy with them, sent them for MRI, and they have had a fracture. So clinicians must have a high index suspicion and low threshold for further referral on for further investigations with someone with a knee infusion. So again, knee infusions, they're not your Osgood Schlatters and Sinlin-Larsen. That's really key. Now we're at the fractures such as green stick, torus, and bow fractures. So these are your incomplete fractures. So these are commonly your buccal fractures, are when you get a goalkeeper and their wrist gets knocked back and they get wrist pain. That's commonly a buccal fracture. And the Salter-Harris fractures again comes in at this stage. So fractures that affect the growth plate. You can see in the mnemonic there, straight across above, lower or below, to or through, and erasure or crush of the growth plate. Now, it's key as well that you make sure that the parent understands about growth plates in relation to fractures. So, for example, we have goalkeepers who might knock the fingers back and they've got what we suspect to be a fracture of the finger, and you'll go and speak to the parent, and the parent will say, I don't really want to sit in A&E for 4 hours for them just to strap the finger to the next one. And to be fair, what you can say is, look, I do understand what you're saying, but do you understand what growth plates are and the importance of growth plates? So yeah, you might end up waiting, you might have an x-ray, and the management might be that they just body strap the finger to the next one. But the key is making sure that there's no damage to that growth plate, because otherwise it can affect the long-term growth of the hand and potentially the career down the line. And generally then the parents will go and get them checked out in A&E. Now we're on to avulsion fractures. So these occur when a fragment of bone is pulled away from the main bony mass as a result of a sudden tensile force applied because of a powerful muscle contraction. And this is because during adolescence, the tendons are generally stronger than the apophyses. They commonly occur at the apophyseal attachments of large muscular tendinous units, but they can occur at the attachments of ligaments too. So again, in adults, you might be thinking of a more muscle belly, tenomuscular tendon, tenoosseous problem, but in children, acute pain, you've got to be thinking of an avulsion fracture. Commonly, we get avulsion fractures around the pelvis. We've had recently some around anterior superior and inferior iliac spine and ischial tuberosity. You can see here that the age range is around about that mid-academy turn, so around about 14 years. And these players will report kind of acute sudden onset pain preceded by forceful muscle contraction. So it might be that they kick a ball and they get pain anterior hip, and then it's over rec fem spine, so it's going on its own now. Or it might be that they've got pain in over the ischial tuberosity. So we're going to send these on for an X-ray straight away. Just to point out, one of our academy physios, Owen, did a case study on some pelvic avulsions that we had. So just point you towards that if you want a little look at some fracture rehabilitation timescales. Other avulsion fractures that you might see is a Watson-Jones fracture or Ogden classifications, and this is a tibial tubercle avulsion fracture. These are relatively rare with a mean age of around 13 to 16 years. My next question was to the literature was, does Osgood-Schlatters cause it? Is it causative? And it's debated in the literature if there is a correlation. The only thing that I can say is that within the time at United, I think we've had 2 tib tubercle avulsions, and we've had multiple cases of Osgood. So the rate certainly isn't very, very linear. Tibial spine avulsion fractures in your younger players, so mean age around about that kind of 11, 12 years. If you've got a player that's reporting an injury which looks a bit like an ACL, so really kind of like hemarthrosis, really swollen, and it clinically mimics an ACL, you need to be thinking, is it a bony avulsion from the insertion of the intercondylar eminence? So we're going to refer these on for an orthopedic referral straight away. Another one for your differential diagnoses is a calcaneum avulsion fracture. These are rare paediatric injuries. I haven't seen one, but it is differential in relation to severs. So if you have got a child who's coming in very much limping, very, very painful and acute onset pain in the heel, you need to consider, is it calcaneum avulsion fracture and not just severs. So we're now on to the serious and sinister pathologies. Starting off with pars defect, spondylolysis or spondylolisthesis. So clinically, these players may have excessive lordotic postures. This may increase the risk, but causes are unknown. On assessment, they may have unilateral tenderness on palpation. Stalk test was commonly taught for pars defect spondylolysis, lumbar hyperextension and rotation. But a study by Alcani said that they thought that this was no value. So I'll let you be the judge of that. Symptoms is unilateral low back pain, plus or minus pain that radiates into the buttocks or legs. It can be gradual or acute, but it starts restricting the daily activities. They'll come in and say that it's worse after strenuous activities. It's generally worse with lumbar hyperextension, and they'll come in, they'll be saying to you that it's worse. So they get maybe a stiffness first thing in the morning or after a long car journey, and they're getting pain after that they've finished training as well. Low back pain, then start thinking about, is this a spondy? We're going to generally at the club refer for an MRI, but it can also be seen on a plain radiograph with this kind of Scotty dog appearance. Slipped upper femoral epiphysis is of unknown cause, but it may be related to the increased shearing forces and weakness of the physis during adolescence. So you can see here a normal pelvis and normal kind of femoral head. So I was trying to look for the mouse to show you. And you see on the other side that the femoral head there is slipped. So sometimes I've explained it as 2 ice creams being held up, and one of the ice creams is just starting to slip off the cone. It's a male to female bias with an age range of around about 10 to 17 years, but an average of 13 to 14 years, and a little bit younger in the females. Signs and symptoms, these may have pain in the hip, the thigh or the knee. They might walk into the treatment room with antalgic gait, have reduced hip range of movement, and the hip may be in internal rotation or have a leg length depending on the level of the slip. and this can be a sudden or a gradual onset. So males more than females are apparently affected by this. If you suspect it, the key is with this is an immediate referral to A&E. We're going to get them on elbow crutches, and we're going to get them non-weight bearing until we know the stability of that epiphyseal. Serious and sinister pathologies and tumours. Starting off with the sarcomas, we need to really, these are the ones we really don't want to miss. So osteosarcomas can occur in the femur and tibia, humerus, skull, jaw, and pelvis. But look at this, it's most common in teens. First peak is around about 10 to 14-year-olds. Second peak is over 65s. But the key is here is that it develops in areas where the bone is growing quickly. So it's near the end of the long bones. So are you thinking about when you're getting kids in with your Osgood-Schlatters type pain, are you asking them the red flags and making sure that there's no signs of any osteosarcoma? Because these types of things can cause night pain or more pain with activity or more swelling as well. So just use it as your differential diagnosis. Ewing sarcoma, most common places for it to start is the pelvic or hip bones or the chest wall, such as the ribs or shoulder blades. So, think about your goalkeeper who comes in and they're reporting pain in the chest wall and they're giving you a bit of a vague history. Make sure you're not just putting it down to that they've been diving around. Again, are you asking the red flags questions and making sure that you're ruling everything out? Rhabdomyosarcomas is sarcomas of the skeletal muscle cells, and this can occur in teens and adults, but it's commonly found in children under 10. And they may have like lumps or bumps swelling on and potentially bowel problems as well. Another one that we generally don't think about in the younger age groups, but it is there, is testicular cancer. So it can affect men between the ages of 15, as young as 15, up to around about 49. So again, make sure if your child's coming in and they're talking about groin pain and you feel like they're not telling you everything, just be aware, are they trying to hide something because they're a bit embarrassed, because testicular cancer can be occurring within the academy age ranges. So next on to the inflammatory arthropathies. Firstly, we've got ankylosing spondylitis. So this is an inflammatory spinal condition of unknown etiology, often presenting in teenagers and young adults, with 2 times more males than females having this. They may report pain and swelling of other joints and have reduced spinal movement and potentially limited chest expansion, depending on how far on the disease is. They may be telling you that they've just got extreme fatigue, but they may also report pain over the SIJ. So again, when you're looking at your differential diagnoses and you've got your back pains, are you considering asking them the other questions about fatigue and about other joints as well? This can be difficult to diagnose. Usually involves back pain and stiffness lasting at least around about 3 months. It often doesn't improve with rest, which things like the spondylolisthesis will, and it might wake them up during the night. Movement activity can help. Investigations, x-rays can show changes, but not always helpful in the early stages. May show inflammation of SIJ, but on MRI, we're looking for inflammation or structural changes. We can also check the bloods as well, because 9 out of 10 people with AS carry the HLA-B27 gene. So really, again, our job as physios in an academy setting is to identify and then pass on to the club docs, who will decide whether to refer on. Juvenile idiopathic arthritis, again, comes under rheumatological, and this juvenile because it's onset before the age of 16, idiopathic because the cause is unknown, and arthritis means that 1 or more joints are inflamed, and usually for at least 6 weeks. It often starts in a knee or an ankle. So again, you player that's coming in with a swollen knee, are you using this as a differential diagnosis? So swollen knee is, like I've said before, is not your Osgood-Schlatters. Are you thinking about osteochondritis dissecans? Are you considering juvenile idiopathic arthritis with a swollen knee? So asking them questions, do they have a fever? Do they have any swollen lymph nodes or a rash on the trunk? And some forms of juvenile idiopathic arthritis are more common in females. So key point here, take care in ascribing joint swelling incorrectly to trauma. Be careful of these ones with the inconsistent histories. You may ask them questions such as, have they had recent UTIs, tonsillitis or gastroenteritis, or consider STIs in an older adolescent. In the absence of trauma, the literature says that the most common cause of swollen joint is juvenile idiopathic arthritis. Within our population at the academy, we find it being more osteochondritis dissecans, but this is just what the literature says. In a well child, blood tests and radiographs can be normal as well. Again, you're going to refer on to your medical doctor if there's any concerns. They'll do bloods, so ASRs, CRPs, rheumatoid factors, CCPs, which is another antibody that may be found in the bloods of children with juvenile idiopathic arthritis. Okay, so now we're up to infections that occur, and we've got two really. So septic arthritis, this is synovial joint infection. Causes is because if bacteria gets into a joint because of an injury or cut or surgery, or germs may even spread from other areas of the body. It can be an increased risk if the player has a reduced immune system, and the presence of gonorrhea increases the risk. So your player may come in with severe joint pain and joint swelling. They may be generally unwell, have a temperature, or feel just hot and shivery. Symptoms may develop over a few days, so go from nothing to quite a swollen joint quite quickly. And really, these are urgent medical referrals on to aspiration antibiotics. You're not going to be waiting for your medical doctor to come into the academy the next day. You're going to be sending these players straight to A&E. Here we've got osteomyelitis. We've got a bone infection caused by Staphylococcus bacteria. And again, this can be following trauma or joint surgery and can be indirect through infection spreading through the bloodstream. So are you asking your players with the swollen knee, are they well? Have they had any recent illnesses? No, so tooth abscess, ear or sinus infection can cause these. Symptoms in prepubescence, it's frequently the long bones, femurs and tibias, and they may have pain, swelling, redness and warmth over the area of bone. They're generally unwell when they present, but maybe not in the early stages. They may have a temperature or again feel hot and shivery. These again, urgent medical referrals. We're not going to be referring on to our doctor the next day. We're going to be speaking to our doctor on the phone that night and sending them straight to A&E. So what about the non-accidental injuries and the safeguarding concerns? These are the ones that we really do not want to see, but we need to be aware of them in case they come up. So considerations in detecting NAIs is inconsistent history. Have they had a delay in seeking help for an injury? Are they attending multiple injuries to the physio room? Maybe you can't quite work out how they've got all their injuries. Are the bruises and bruise areas consistent with the sport? So think about the classic bruises at the top of the arm, inside of the arm or inside of thighs, can denote either physical or sexual assault. And is the player actively trying to hide the injuries or bruises, or trying to hide, maybe they don't want to take the top off in the treatment room? We're going to refer them on to the club safeguarding officer. If you can also have children as well who kind of tend to have multiple attendances to the treatment room, and we need to be aware as well, is there other things going on? So I remember treating one boy who assessed for something, sent back out thinking he was fine. He literally must have touched the bottom step of the treatment room and he came straight back up to the physio room and told me about something else that was injured. That was a little bit of a flag to me to think, hang on, let's sit this boy down and find out what's going on. He was having a little bit of a bad time with another child in the group and was a bit fearful of going training that day, so we sorted that out. So be aware, is it about performance in the group, bullying, is it parental pressure or an issue, or are they worried about an upcoming game or tournament? Because how we feel emotionally really affects our physical state. So think about if you're having the best night of your life and you're out with your friends and you bang your knee, okay, you kind of, you rub it, you get on with it because you're having such an amazing night. Now imagine the same pain, the same injury, but you've had the worst day ever. You're really feeling down, you bang your knee, the exact same injury can produce a completely different emotional response. So many times I've talked about we'll refer on. Okay, so actually at Manchester United at Carrington, we have ultrasound, we have an MRI, and we have a CT scanner all available within the training ground complex. But it's important that as clinicians working with paediatrics, we actually avoid over referrals. So we only refer when it's clinically indicated. We don't want them just to be going thinking they're going to need a scan for every injury that comes through the door. Similar with taping and manual therapy, we want to avoid creating unnecessary dependency on tape or manual therapies. And we have a consistent approach between physiotherapists regarding indication for an application of taping. And we even have like a manual taping techniques booklet so that when new physios come in, they've got an idea of how we do it. And that's from the academy team right through to the first team. So rehabilitation. In both adults and children, rehabilitation typically follows a phased approach where a graduated loading program process is adopted. Criteria-based approach guides the transitions between the phases, and this is goal-orientated, considers healing times and restraints, considers functional capacity, and is individualised. And at the end of this rehab process, the aim is to have a robust player who returns to play able to cope with the demands of their sport. So what are the principles more than that we use is really about building things up. So from simple to complex movements, we get good movement patterns before we add on load. We look at gaining strength before power. We move from control to uncontrolled movements, from low to high, for example, like jumps. We'll start with linear type work, moving to multi-directional, and things like short passes, moving into long passes. Slow to fast movements. Throughout the rehab process and even the return to play, we're going to think about the volume, the intensity, and the duration. And key is really that we keep everything developmentally appropriate. So it's about getting the balance right between challenging children appropriately, but avoiding asking them to perform an exercise beyond their capability. Okay. We're going to try and make the rehab process fun. So define fun for the player. If you're working with an under 16, fun might be, Di, let me get my physio done and I can get out and watch the second half of the under 16s game. It might be that you get them working together, or you might be working them against each other. Sometimes works, all pictures are pre-COVID. We might give them incentives, so get your rehab done, we'll have a game of basketball. Or it might be that you get forfeits. Whoever loses is going to get some press ups. All right. So we try and make things fun as well. Can't be all the rehab session, but at least part of it, trying to make it fun. And just remember really that you can do the best rehab session, you can do the best phase rehab, and the kid will come in with dirty knees and they're worse. They've made their injury worse because they've been playing football during the break at school. So you know what? Kids will be kids. Expect them to make mistakes. Rehab is a learning opportunity. It's all about education through this phase. So in summary, as academy medical staff, we require a clear knowledge and understanding of paediatric injuries and conditions, and we must understand when to refer on appropriately whilst avoiding the over-medicalisation of children. But just before I finish, I just wanted to point out some chapters that I've just recently written in Sports Physiology and Injury Management book. Now, I'm not putting this on because I get any royalties, because I really don't. But the reason that my whole aim of writing these chapters was to help people who were starting off their journey in sport. So, you know, an introduction to working in elite football, what do you need to know? What does biobanding? What does relative age effect? What does peak height velocity mean? So all those kind of terminologies. And then more of what I've talked about tonight in relation to anatomy and fractures and osteochondrosis and serious paediatric conditions. So if you're trying to get into sport and you want something to start with, and hopefully that'll be of some use to you. So thank you for your time, and I should obviously ask, what questions do you have?
Lots of questions.
Goodness.
They're all nice ones though. They're all nice.
Good.
No one's been too harsh on you. That was fantastic. I can't believe how much you managed to fit in into such short space of time. Really, really valuable.
Thank you. Can't see anyone now.
Let's dive into these questions then. So we'll go top voted first, and then I'll start cherry picking because some of them you've answered in part anyway, as we've been through. So first question's on RED-S, relative energy deficiency in sport. How influential do you think that is with injuries in younger athletes?
I think that there's going to be another talk which is going to go into that in a little bit more detail. To be honest, it's coming up on the next one.
Cool.
So that might be one to answer that a little bit better. So I think I don't want to kind of go into someone else's talk, but I think that's what they're going to be covering in a lot of detail.
Cool. Right. So we talked about PARS fractures, and you mentioned stalk test. So as soon as you were talking about the kind of validity of stalk test, questions started flying in. So thanks to Glenn Berger on for being in there first with this one. What are your alternate tests, and what's your kind of battery of tests for PARS?
To be honest, a lot of it's subjective. a lot of it comes from subjective. So as soon as they've had a couple of weeks, they'll generally present, and the general presentation is a couple of weeks on, I've been getting this back pain that it's not been stopping them training, but it's just been niggling them. And then a couple of weeks later, they'll come to you, the physio room, and then they're starting saying, it's starting to be, sore first thing in the morning. It's sore when they get out to the car for training. It's sore after training. Subjective is the real key for me. For whether I'm worried about it being a PAS. The other thing then is how they respond to normal treatment. So it doesn't mean that we'll put everyone through a scanner. It might mean that we might give them a short period of normal physio, normal back kind of strengthening exercises, mobility, whatever, and just see how they progress. And if we're worried about the progression, then we'll look at scanning them really. But I still use back extension. We'll close them down on that side, because it does seem, for the ones that I've treated, it just seemed to promote a response. That's what literature says. That's what I said. Make your own mind up. Really, you're going to do extension and side flexion. It does seem to give a pain response on the PAs that I've seen, but that's
mostly subjective. And putting the
a lot of subjective
picture.
Failure to progress during normal rehab. If they're not progressing after a few weeks, then we'll look at scanning them. But subjective history that it's been going on for a little while before they've presented to you. And those key, stiff when I'm getting out of the car, sore after training, starts flagging up a little bit.
Cool. Nicola's question, this one's on loading. So the best way to manage load in players with growth-related conditions. I never know how much to reduce them initially, because I want to keep them as active as I can.
Yeah, I think it's the $1 million question, isn't it, to be honest, about loading in players. So how we manage it at United is... So imagine someone's going through peak height velocity, and what do we do with the load there? So there's some theories that say, as soon as you know that they're going through peak height velocity, you're going to reduce the load for them. And then there's other theories that say, well, actually, if players can get through, and this is the one that we're using more at Manchester United at the moment, if players can get through the normal programme and cope absolutely fine, then why would we reduce the load just because they're going through a normal process of growth? So, but the key is that we educate the parents about growth-related pathologies, and we educate the children. So the idea is that as soon as they're getting any type of kind of Osgood-Schlatters type presentations in the last, that they're going to come and see us so that we can manage the load effectively from the start. So education is going to be really key. But I think there's going to be a lot more research in this over time. But I think the other key as well is that when we're talking about load, we're talking about, exposure time, intensity, duration. And in academies, we sometimes, yes, we'll know how long that they're training for. We don't always have the intensity. The younger players are not all using GPS. So it's a topic that I think will expand over time.
I'm going to tie in one of the other questions as well, because you mentioned that kind of rate of growth. And someone asked, will you reduce load if they gave an example of 1.5 centimetres a month kind of growth rate? Are there any sort of hard and fast rules for that rate of growth that you'll look at?
Yeah, no, what happens at our club is the athletic development department, they produce the charts and they work out the percentage of adult height. So we've got an idea of where they are and whether they're going through the peak height velocity at that time. So we'll get a chart that says either the pre, during, or kind of post peak height velocity. And it's just all about educating the MDT. We all have that information. Players are made aware of that information. But no, we don't just say this is a cut-off that therefore we reduce. Because the other thing is it's about timing and tempo when we're talking about growth. So it's not just that they've grown, they might have grown in that 6 weeks, a short amount, but have they actually grown that within a week and a half? So timing versus tempo is key as well. And I think that's where there's going to be more research over the next few years as well. It's not just going to be how much they grow, it's going to be about how fast they grow as well.
Bro. Nicola in with another popular question. Any tips for rehabbing players when we've got no indoor environment? She's restricted to outside training at the moment and then home exercise plans. So any golden nuggets?
To be honest, we found ourselves in a very similar position during lockdown. That we were just rehabbing people in their own homes. And I think you go back to your basics, isn't it, really? Went back to we went back to thinking about working in NHS clinics when I had nothing and I had no rehab equipment, what I did. So it's just about being back to basics. What I would say is I used with one of the boys, like as a virtual, is probably the nearest way that I can say is we used a lot of giving them ownership. So, for example, I would give them a sheet with exercises on, and then we had to get him to pick each session what he was going to do within that session. So he was then learning how to put his own plans together. And then it was like kind of true or perceived ownership. So he didn't have true ownership that he could choose everything, but I would say, what do you want us to do today? And he would kind of put a plan together. And I would say, well, maybe we've done that last time, we do this. So we use it as a real kind of ownership and them taking some responsibility for themselves. But yeah, it actually makes you really, really think as a therapist. When you lose all that equipment, we've lost the access to swimming pools, to all that. We used to use the same gym as the first team, so it was getting everything up and running in the academy and what you need. And actually, so much you can do on a pitch with some cones and some very, very basic equipment. You don't always need everything so fancy.
Backpack with some tins of beans in it and some other heavy stuff.
Yeah, bags of sand and
Right, we're going to try and squeeze in a couple more questions. I'm conscious of the time, but we'll go for it because there's a couple of popular ones. So I'm going to go there. It's a tape question. You mentioned it in part because you said you've got like the handbook, taping methods, and everyone's on a level playing field, and you try and restrict access to tape. Someone's asking about K-tape specifically. When would it, do you use it at all? And if so, when would that be indicated?
Okay, so the general principle around taping. So for example, I'm not going to stop ankles being taped, say with a basket weave tape, if they post ATFL or a CFL injury and they're returning. What I'm saying about the taping is that what we don't want is for them to be having that strap in from being 12 through to going up to under 18s. So the idea is that if you're going to put tape on someone, there's going to be an end point to it.
Yeah.
Okay, so we're going to then maybe go from a figure of 8 quite hard to a basket weave to a figure of 8 and then wean them off really. K-tape is not something that we use a lot, to be honest, at the academy. Occasionally clinicians have used it, but generally, again, it's not something that we choose to use a lot.
Yeah, I thought that might be the case. Question on osteochondritis dissecans, normally unilateral or can it be bilateral?
The ones that we've had recently, we've had a couple, they've been unilateral, but potentially if that problem's there, then I think there's always a potential that it can be unilateral, bilateral. But yeah, unilateral has been the ones that we've seen.
Last one. I've just seen a really good question. We won't ask it because I'll be fair to the person with the more popular one. Last one, about communication. So in a non-COVID world where you do an assessment with the child and the parents there, do you give the kids and the parents different information or do they all get the same comms?
Same information in relation to...
in relation to their injury, would you give more detailed, more complex information to the parent or would the education be the same for both?
That's a really good question, actually. So for the whole, so for example, if it was just like an Osgood, then it would be exactly the same for the player and the parent. We would explain everything to the player, parent can ask any questions as well. If it was something that we maybe thought, well, we don't want to worry the child at this point, like a back pain, we might maybe say to the parent, look, we're just warning you that potentially if this doesn't get any better, we may look for scanning it because there is some other conditions that we might be looking for. It just depends on the situation, really. But generally, we're as open as we can be with both player and parent.
Great stuff. We'll leave the questions there and we'll get things wrapped up. Andrew, I don't know if you want to come back in. Just some little housekeeping bits from me as we wrap things up, just to make sure I've got all bases covered. When we boot you out, which will happen shortly, you're going to get directed to a survey for this evening. So please let us know your thoughts. Please take a couple of minutes just to fill that in and give us your feedback. It's really valuable for us in terms of planning future events, and obviously we'll pass on all your lovely comments to Di as well. You'll get an email with your certificates for this evening with a link to the recording. That recording will be time limited, so catch up on it soon. before it goes. And we'll give you a link to follow Di on Twitter so you can ask any follow-up questions and stuff like that. Is there anywhere else that you'd rather people send you questions, Di, or is Twitter fine?
No, that's fine. That's fine.
Awesome. You might get a sudden boost in your social following. I've got a feeling. Like we said before, if you're not already a member of BASRAT and you would like to support our work, please give us a shout, and you can follow us and Sterasport on Twitter. Di, thanks very much. Andrew, I'll hand it to you to do the wrapping up for this evening.
Yeah, no, thanks, Ollie, as always.